Hello, ladies and gentlemen. Today we are going to see about regional anesthesia, a fight against connective tissue barrier. This is quite a broad topic. I want to make you interesting. I know the brain only functions for 20 minutes, and later on, whatever the things that you see there, the brain is not receptive to what you get into. But I am going to make it very interesting. For decades, ladies and gentlemen, from Winnie's era, this regional anesthesia is always a fight against connective tissue barrier. I'm going to tell you why. Before that, this is one of my fresh cadaver dissections where I've dissected the brachial plexus. You can see the C5 nerve root, the C6 nerve root, which joins to form the upper trunk. This is a C7 nerve root which continues as a middle trunk. The C8 and the T1 which forms the lower trunk, and then lower down you can see the subclavian artery. And what you see is here is the first rib. This is another fresh cadaver dissection done by me showing the lumbar plexus. You can see the L1 nerve root, the L2, the L3, the L4 which forms the femoral nerve, and you can see the obturator nerve also. So I'm not deviating from the topic. The topic per se here is regional anesthesia, an era of fight against connective tissue barrier. That is what I'm here to prove to the whole world. Let's see. So thinking about this topic, what should I tell you and make you interesting? Let's say I thought of talking about delayed onset in peripheral nerve block. Say we are giving spinal anesthesia for decades, isn't it? So decades of spinal anesthesia, we are giving 3 ml of 0.5% whatever desired local anesthetic we use. We get the desired response, that is a sensory and the motor blockade in 3 to 5 minutes. But why are we getting the delayed onset in a peripheral nerve block? That is one. And second is, why larger volumes of local anesthetic is used in a peripheral nerve block? Third is, what is happening after injection of local anesthetic? How are we going to improve? Are we still using 20 ml of local anesthetic for a peripheral nerve block using ultrasound? No, it's not so. I'm going to prove that also later on. Just fasten your seatbelts so that let's make it very interesting. We know spinal anesthesia, we perform at L3, L4 level. We give 3 ml of 0.5% bupropion, and then we give 3 ml of 0.5% bupropion or any other desired local anesthetic, and it blocks 26 segments just below T10. The onset is around 3 minutes, 3 to 5 minutes. It's very faster than a peripheral nerve block. Why is it so? But still, with the evolution of ultrasound, we are not able to block the brachial plexus, that is, which involves just 5 nerve roots with 20 ml of local anesthetic. We are using the same amount of 0.5% local anesthetic concentration in a brachial plexus block as we use in spinal anesthesia, but still we are not able to get the onset, the faster onset as in spinal and a delayed onset in a peripheral nerve block. Why is it so? Ladies and gentlemen, you can directly visualize, you can see how much connective tissue barrier is around the brachial plexus block. Brachial plexus. So So if you have to have a, call it as a spinal anesthesia of arm, you need to breach these connective tissues and perfectly place the drug, the desired drug, the right sweet spot of the nerve, which I call the paraneural space. And then you will get the faster onset, just like spinal anesthesia, and you call it as spinal anesthesia of arm. So in spinal anesthesia, we are using 3 ml of 0.5% bupropion. This 3 ml mixes with 40 ml of CSF, lumbar CSF approximately. This 15 milligrams gets 10 times diluted, and the end concentration that reaches the naked axons, which is just 0.03% of your local anesthetic, which sits on the roads of Raniver, and it further prevents further propagation of high action potential, and then the dense blockade and sensory blockade. This is what happens in a spinal anesthesia. What is the advantage you have in a spinal anesthesia is the local anesthetic mixes with the CSF, and it takes this local anesthetic with the CSF all around the spinal cord and blocks densely to get faster onset. This local anesthetic breaches the pia mater. You have natural fenestrations in the pia mater to reach the naked axons, where the local anesthetic sits in the roads of Raniver. This we all know. Ladies and gentlemen, now say we have given a spinal, we are getting faster onset. So in epidural, this is the dura mater. You are giving the drug above a layer of connective tissue, that is the epidural space. You are giving more, 15 ml of 0.5% of the any desired local anesthetic that you use, 0.5%, and still you are not able to achieve the dense blockade as just like spinal. This is because you have a dense connective tissue. This is nothing but your dura mater, which is all made of collagenous matrix. You can see the dura mater there. And this dura mater is very much permeable to the local anesthetic. And this local anesthetic has to breach the dura mater, and has to reach the naked axons into the spine subarachnoid space to have a dense blockade. And rest of the drug gets absorbed in the epidural fat and also through the epidural veins to reach the plasma concentration. You can see the dura mater around the spinal cord. When you look into the cut section, you can see the dura mater there around the spinal cord. And then that's the epidural space. You're giving the drug just above the dura mater, and the drug has to diffuse off through the dura mater to bath your naked axons. When you look into the electron microscope, the thickness of the dura mater, which is around 250 to 400 microns in thickness. If, ladies and gentlemen, you need to think that the drug has to, these are around 8, these are not just one thickness of dura mater. There are 80 layers of dural laminas. The dural laminas are like 1, 2, 3, 4, 5, 6. That 80 dural laminas like that, and the drug has to, and these are permeable to the local anesthetic, and they have to, when you deposit the drug just above the dura, the drug has to diffuse off through the dura mater to bath your naked axons. So just imagine, this is a connective tissue barrier for your epidural anesthesia. So finally, the endpoint is to breach your arachnoid mater, pia mater, and the endpoint is to reach your naked axons. This is an epidural drug study which I did with MRI with the galodinum isotope. I performed the epidural at T7, T8. and threaded my catheter 5 centimeters inside. So that tip is roughly around T6. I have given 2 ml of local anesthetic with the galadium isotope. Look at the drug spread from T5 to T9, T10. So it doesn't mean that thoracic segments, if you give 2 ml, the drug settles in for one segment of the thoracic. It doesn't mean like that. That is an entirely different entity, which I'm not going into it. But anyway, I'll emphasize a bit on it. When you give 15 ml of local anesthetic and you wait for 15 minutes, the drug spreads from T2, roughly from T2 to T12. You can see here, the drug seeps to T12. So the drug blocks around 10 segments of the thoracic. So that means around roughly they calculated, that's the experts that they have calculated, which is a roughly for thoracic segment, which is around 1.5 ml per segment. That what it means. What I'm coming here to say is, as we all know, for an epidural, the dura mater is a dense connective tissue, which is the barrier for the epidural anesthesia, as I have told you. And what I did is, I have given 15 ml of local anesthetic with the galadium isotope, and then I did the cut section, axial section at 1 minute. Let's see what happens. You have an anterior epidural space and posterior epidural space and the foramen, as you all know. So what happens is, first the drug settles in the posterior epidural space. You can see the drug just exiting the foramen and still in the posterior epidural space. For a good dense blockade, just like spinal, as I told you, you need to have a donut shape appearance, that is the local anesthetic bars to the anterior and the posterior epidural space to have a dense blockade like spinal anesthesia. But here at the first minute, when after you have given the 15 ml of local anesthetic with the galadium isotope, still the drug settles in the posterior epidural space. Again, when you go down, you can see again in the posterior epidural space, not in the anterior epidural space. As you go down, you can see still in the posterior epidural space and some of the drug exiting into the foramen. But if you wait for 15 minutes, yes, you can see there, okay, if you wait for 15 minutes, the drug starts seeping into the anterior epidural space. When you take cut sections again from lower, you can see the drug starts from seeping into the anterior epidural space, posterior epidural space, and starts seeping into the foramen. Here also you can see the drug spread in the posterior epidural space and also a bit in the anterior epidural space. Now you can see in the lower cut sections, you can see the drug spreads well on the anterior epidural space, exiting to the foramen and also in the posterior epidural space. For a dense blockade to happen, so unless you wait for 15 minutes, the drugs engulfs all around the dura mater, that is the anterior epidural space and the posterior epidural space, and then the connective tissue barrier for the epidural anesthesia is a dura mater, which is permeable to the local anesthetic. So the local anesthetic has to breach off the dura mater to reach the naked axons to have a dense blockade. That is why there is a delay in onset of 15 to 20 minutes. That is why I call regional anesthesia a fight against connective tissue barrier. This happens with epidural. Let's see what happens with peripheral nerve block. In a peripheral nerve block, you can see this is a cut section of a spinal cord. This is how the nerve root exits. This is one of my dissections. You can see the nerve roots. That's how when the dura is open, this is how the phylum terminale and then the nerve roots exits. But the interesting point, what you have to think is, when you take a cut section here at this level, the histology that you get is when these nerve roots come out of the spinal cord, the nerve roots are well safe in the subarachnoid space. The CSF is a very protective barrier for your naked axons. When these naked axons gets out of these through the foramen, they have no other choice. They have to take the dense connective tissues around the vesicles. So the dense connective tissue around the vesicles are only barrier for the naked axons for your to prevent our needle and your local anesthetic from traumatizing those naked axons. That is the beauty of God's creation. When you take a peripheral nerve cut section, you all know what are the layers are. You have an outer epineurium and an inner epineurium which bring the fascicles, each fascicle together, and each fascicle is covered by a perineurium, and perineurium is one of the toughest layer that even a short bowel needle can't even cut through the perineurium. That is being proved actually. So, and inside the perineurium, you have all naked axons. Each naked axon is covered, myelinated axon is covered by a layer called endoneurium. So you have a lot of connective tissues like outer epineurium, inner epineurium, perineurium, and endoneurium to safeguard your naked axons. This is a cut section of a sciatic nerve when you look into the electron microscope. So I have to run through certain things. As you all know, Miguel Reina has brought out the electron microscope imaging of each layers of endoneurium, perineurium, and epineurium. I'll run through it. So this is the endoneurium. But when you read through the Snell's Atlas of Neurosurgeons, this endoneurium is not a layer. It is made of, you can see dots. These are collagenous matrix. It is not a layer. It is the collagenous matrix which engulfs the myelinated axons. And this perineurium, as you look here, is not a single layer. When you zoom in, you can see they are multi-layered. 8 to 12 perineurium layers for each vesicle. That is a very protective barrier for your axons. And another protective layer is your epineurium. You have outer epineurium and inner epineurium. This is the outer epineurium and this is the inner epineurium. And you can see the thickness of the epineurium. So when you deposit a drug, say if you want to deposit a drug here, just imagine the drug has to seep all the epineurium, the perineurium, and the endoneurium to reach the naked axons. So that is why I call this peripheral nerve block or a regional anesthesia in toto is a fight against connective tissue barrier. Is been for decades, which certain people know, which certain people don't know. That is why I'm here to deliver this topic. This is an article which looked into the ratio of connective tissue barrier to the neural elements in a brachial plexus. So this is a supraclavicular brachial plexus. You can see there. This is a subclavian artery there. This is the connective tissue around the brachial plexus. These are the neural elements of the brachial plexus. Just look into the gray shadows versus the dark shadows. You can see the ratio of connective tissue versus the neural elements. The connective tissue is more in the brachial plexus. Suppose if you are going to deposit the drug outside this gray shadow, just imagine the time to diffuse off the drug through the connective tissue to reach the naked neural elements, that is the naked axons, it will be much more. Then you cannot call it as spinal anesthesia of arm. If you want to call it as a spinal anesthesia of arm, the ultrasound provides you an information that you have a paraneurium around each trunks of brachial plexus. You need to dissect out the paraneurium of each trunks of brachial plexus and deposit the drug in the right place. That I will show you. This is a microtome cut section of a median nerve. You can see the fascicles and then you can see the interfascicular level, and then you can see the yellowish structure, which is also a dense connective tissue around the median nerve. This we all know. This is a well-known figure, which you can see the fibular component and the tibial component. You can see the paraneurium around the sciatic nerve. But Manoj Karmakar demonstrated the paraneurium of the sciatic nerve and the epineurium. Between the epineurium and the paraneural sheath, you have a paraneural space. When you deposit the drug in the right place, that is called as the paraneural space, you have faster onset and prolonged duration of analgesia. Here, this we all know, but in brachial plexus, the paraneurium, to me, what I have observed, this is all my perspective. I want to deliver in my channel. What I feel is each nerve in a human body has a paraneurium and a paraneural space, and the paraneural, then you have the epineurium, and then you have the rest of the layers. So the sweet spot of the nerve is nothing but your paraneural space. This paraneural space is very flimsy, and the paraneural sheath is very flimsy, and the paraneurium is around the brachial plexus is very flimsy. And the ultrasound, the high definition ultrasound, it does show you, and the fresh cadaver dissections does show you the paraneurium of these brachial plexus, that is the upper trunk, middle trunk, and lower trunk. So my idea is to dissect out the paraneurium of upper trunk, middle trunk, and lower trunk. When you deposit low volumes, that is 3 to 4 ml of local anesthetic for the upper trunk, middle trunk, and lower trunk, you will be able to have a successful spinal anesthesia of arm with 10 to 12 ml of local anesthetic without any compromise to your phrenic nerve. That is my motto. This is another fresh cadaver dissection. You can see the paraneural sheath, the common, the peroneal nerve, and the tibial nerve done by me. And ladies and gentlemen, this is what I want to highlight. What you on the look on the left side is nothing but your atlas, what you see. Right side is one of my fresh cadaver dissections. What's the difference that you see? Left side, they have dissected out all the connective tissues. But ladies and gentlemen, in reality, brachial plexus have a dense connective tissues. These are the dense connective tissues around the brachial plexus. So you need that. This is nothing but the dense paraneurium. You need to dissect out the paraneurium of each trunks of brachial plexus and deposit that drug. That is what I'm here to deliver. So I have dissected. Here you can see Miguel Reina has showed the paraneurium at the brachial plexus level. I have dissected the paraneurium of upper trunk. As you see here, this is the clavicle. This is the upper trunk. This is the cephalad. This is the chordate. You can see what they are lifting is the paraneurium. Only in fresh cadaver dissections, that is why people are moved from cadaver dissections, frozen cadaver dissections to fresh cadaver dissections to clearly differentiate the paraneurium, the layers of brachial plexus. I'm in 2022, I have done these dissections 3-4 years before. But in 2022, I'm registering that this is the paraneurium of the upper trunk. When you are able to identify this paraneurium of the upper trunk and deposit the drug, that is 3 or 4 ml of local anesthetic for each trunk, you will be able to have a successful brachial plexus with low volume of local anesthetic to call it a spinal anesthesia form. There is another fresh cadaver dissection. You can see here, that's the upper trunk. This is a clavicle. That's the upper trunk that is going there. You can see the paraneurium that is being reflected from the, you can't reflect the epineurium just like this. Only you can see reflect the paraneurium like that, and you have a potential space in the upper trunk. I did a contrast study. Under ultrasound guided, I placed my needle breaching the paraneurium and placed 2 ml of contrast. So when you have a potential space below the paraneurium, the drug spreads in a longitudinal manner along the long course of the nerve. But if you are inside the epineurium, the nerve swells. Similarly, I have identified the middle trunk, the paraneurium of the middle trunk, and deposited the contrast. And the drugs moves up and down along the long course of the middle trunk. So the idea is to deposit low volumes of local anesthetic for a successful blockade, faster onset, and to prevent phrenic nerve blockade in a very demanding individuals. So I like to call this space, this sheath, as a conduit for injecting LA, a path allowing for nerve gliding, a layer of protection against nerve trauma, that is the paraneurium. This is also a beauty of God's creation. Manoj Karmak and Miguel Reina demonstrated the paraneural space, subgluteal space of the sciatic nerve. They have demonstrated the paraneurium brachial plexus. They have demonstrated the paraneurium at costoclavicular, the paraneurium on the infraclavicular. I done a costoclavicular in 2016. You can see there are individual spaces for each cords of the brachial plexus. This is a posterior cord, this is a lateral cord, this is a medial cord. There is a potential space for each cord. This potential space is nothing but the paraneural space. This is very interesting, which is in 2016. See, just imagine, you can see that is a lateral cord, this is a medial cord, this is a posterior cord. When you inject, you can see the paraneurium around the medial cord, and there is a separate compartment for the posterior cord and the lateral cord. These layers are very flimsy layers. Suppose if you are imagining that you are doing a PNS guided infraclavicular block, so then your needle is approximately on the medial cord and you are eliciting finger flexion. Why I'm saying this layer is a flimsy layer is, when you get the finger flexion, sometimes you may be inside the nerve or outside the cord. You will be giving around 30 to 40 ml of local anesthetic. What happens is this paraneurium of the medial cord disrupts, and then later on it barks the lateral cord and the posterior cord. That is why you have a U-shaped drug spread. That's what they say. So the onset is always very delayed in such cases. This is what Dr. Shivashanmugam demonstrated. You can see this was published. This is a RCT trial. First, they started with the extrafacial injection with subfacial injection of local anesthetic during ultrasound-guided supraclavicular brachial plexus block. The extrafacial is you're not piercing this fascia, depositing the drug outside this fascia. And subfacial is you need to pierce that fascia, come inside into the brachial plexus and give the drug. And what they found was, I'm just showing, this is extrafacial and this is subfacial. What they found was there's a concluded faster onset and prolonged duration of action. And none of the patients, they followed the patients from 6 months to 1 year. None of the patients developed persistent neurological symptoms. So this is what they found in subfacial. You can see here the time for readiness for surgery. The time for readiness of surgery is defined as the time you finish the block to the onset of surgical incision. What we have found was in extrafacial, the onset is around 20 minutes. In subfacial, which is less than 7 minutes. So the onset is around very close to spinal anesthesia, which is roughly around 3 to 5 minutes. This is how in 2017, this is 27 echogenic short bowel needles we try to go, this is how we did in plane. This is the upper trunk. So put forward, whenever your needle is close to a neural element, put forward your local anesthetic. See, still you are away from the neural element. So what I have to do is I come lateral to this upper trunk and then go to the middle trunk. This is what we did in 2017. Now again to the middle trunk, this is the neural element of the middle trunk. So what you have to do is, you should not breach the epineurium of the middle trunk. The idea behind this, when you stay away from the epineurium of the middle trunk, the local anesthetic that you give will push the neural elements. But when you breach the epineurium, the nerve swells. Here again, the lower trunk, you can see the paraneurium of the lower trunk and the paraneural space, and the lower trunk is being given. And the drug is being given there in the lower trunk. So this is a very interesting out-of-plane technique which I performed in 2018. We can see that's upper trunk, this is the middle trunk, and the upper trunk and the middle trunk. And low down, you will see the lower trunk. What I'm doing is, in out-of-plane manner, slowly hydrodissecting first giving few ml of local anesthetic for the upper trunk breaching the paraneurium, and slowly dissecting the paraneurium of the middle trunk. See, this is the breathing space. I'll pause it here. See, when you breach the paraneurium of the middle trunk, when you give few not even 1 ml of local anesthetic, the local anesthetic pushes the middle trunk, and then the local anesthetic goes all around the middle trunk. That much ml of local anesthetic is much needed for a successful truncal blockade. So just imagine you are giving 4 ml of local anesthetic for the upper trunk, and then middle trunk and the lower trunk. That's 12 or 10 ml is much needed for a successful brachial plexus block. You can see the distension of the space. You can very well see the distension of the very potential space. The drug goes all around the nerve when you are into the paraneural space. But when you are breaching the epineurium, the nerve swells. That also I'll show you. So when you finish off the block, after giving local anesthetic for the lower trunk, you can see the C8 and T1. So now I can tell you, this is the anterior division of the upper trunk. This is the posterior division of the upper trunk. This is a suprascapular nerve. You can see the paraneurial layer. You can see the anterior and the posterior division. The middle trunk, which is about to divide, some of the drug has seeped off outside also. And then you can see the C8 and T1. This is the subclavian artery. This is the first rib, and this is the pupillura. The histology also demonstrates the same. So this is what you should not be doing. Do no harm. See, I have seen young budding heroes who are doing out of plane technique in a supraclavicular block and doing this harm. Kindly don't do it. Kindly just see this video. You can see the pulsating artery, the subclavian artery. and one of my resident is coming out of plane, or in what I'll do is I just put forward the local anesthetic, go, and then you breathe and breathe a paranoia. That's how it's done. It is not the needle is you put the needle and then you after you give the local anesthetic, you see the distinction of the C7 and T8 component. You can see there. See the neural elements being distended. Again, he's scouting up and below to identify the needle dip, still not seen. When he comes out, he has totally distended the lower trunk. Again, you can see that. This is what it is. It should not be done even with high definition ultrasound. What you have to identify is this gets an years of experience to identify the paranurium of these trunks and delivering the drug in the right place. This is not the way to do it. This is not how I want people to do it. We need to dissect out the space and give the drug, or say 3 or 4 ml for each trunks. So again, Dr. Shruti Shanmugam has published the truncal injections. This is going to be the era after this 2020. He has published in Indian Journal. Trust me, also this is going to be the era. For what he has done is, for each trunk, he has deposited 6 ml of local anesthetic. So 666, it comes around 18. He had a successful blockade. This is around patients, 21 patients. This is the volume of the local anesthetic being used. Then he come down with up and down Dixon method. He come down to 12 ml, which is roughly around 4 ml for each trunks of brachial plexus. Then he came around 9 ml, which is roughly around 3 ml for each trunks of brachial plexus. Then he came around 2 ml for each trunks of brachial plexus, which is roughly around 6 ml. He had a successful blockade. Then he came down, then gave around 1 ml to the each trunks of brachial plexus. Then he failed. Then they increased. Then again they failed. Then they increased around 3 ml of local anesthetic for each trunks of brachial plexus. And what they found was the minimal local anesthetic volume that is being used in 95% of the patients was around 10.4 ml. This is what it is basically needed when you have a knowledge of the brachial plexus, the ultrasound, the zone anatomy, the upper trunk, middle trunk. When you're able to define the upper trunk, middle trunk, lower trunk, and then you're able to dissect out the paranurium of each trunks of brachial plexus, then deposit below the paranurium, then you will be able to do a successful blockade in a high demanding patients. So earlier we've been taught like supralateral, this is subclavian artery. Supralateral, you keep the probe there, put the needle in plane. Supralateral, you will see a bunch of ribs. This is a first rib, this is a pleura. And you give the drug above and first you give 10 ml there and 10 ml in the corner pocket, which is not so. The era has been changed. What I'm coming here to say is, just look into this video. First, you need to define the trunks of brachial plexus. This is C5, this is C6, which forms upper trunk. This is a C7, which forms a middle trunk. This is a C8. And later, as you swipe your probe down cephalad, the T1 comes and joins the C8. That's the lower trunk. Again, I'll just play it for you. This is a C5. This is a C6, which forms the upper trunk. Then the middle trunk, which is a C7. Then the lower trunk, which is a C8. And then as you swipe down the probe, you will see the T1 joining the C8, which forms the lower trunk. Unless you define these structures, you will not be able to perform this truncal blockade. So these are bilateral distal radius patient. We are able to perform bilateral truncal blocks. You can see the saturation probe is always unable to do it. We are kept in the foot end. ECG is being monitored. Oxygen is given. No general anesthesia is being provided. You can see the patient is right away sitting up after bilateral plating. Much comfortable. When asked for any pain, patient says no. Any discomfort, patient says no. The total motor blockade. So always when you do a bilateral brachial plexus, supraclavicular brachial plexus block, make sure you always comment to you just talk to them that your limb is going to be blocked for 6 to 8 hours. Make sure that, and then you can go ahead and do it. Ladies and gentlemen, this is patients who are demanding for blocks. This is an obese patient with both bone fracture. Are you going to deposit 40 ml of local anesthetic for this patient? This is a shattered lower end of radius elderly individual who's respiratory compromised. Are you going to give 10 ml of local anesthetic or logs or anything called as low volume interscalene block? No. This is a venous hypertension patient coming with high urea creatinine coming for a supraclavicular shunt closure. This is another proximal obese patient with lots of ischemic heart disease, obese, OSA, everything. These are the patients who are demanding for blocks. So these are the patients where you have to define these structures and give low volume blocks. That is why I'm here to deliver this talk. And also I want to tell that how we started with spinal, and then in epidural anesthesia, you have the connective tissue barrier, that is a dura mater, and the peripheral nerve blood. They have a dense connective tissue, that is the paranoia and the paraneural space. They are also a connective tissue barrier. Totally, and a decades we are fighting that regional anesthesia is nothing but a fight against connective tissue barrier. So I want to leave you saying that this will take you around 2 minutes time, saying that this landmark technique, no paresthesia means no block. We know that interscalene block, supraclavicular block. But in interscalene block, this is an interscalene block, this is a supraclavicular block. If we deposit drug in the interscalene block, this is a fresh cadaver dissection done by me. You can see when you deposit the drug in this interscalene level, say like 40, 30 ml, the drug is even 20 ml or even less, 15 ml. The drug is always going to seep into the anterior scalene, and then it is going to block your phrenic nerve. This is a cephalad end, this is a caudal end. You can see the first strip there. This is supraclavicular block, and even supraclavicular low volume block. See, you can see the drug is always going to seep into the anterior scalene. Even 20 ml supraclavicular block, the drug seeps into the anterior scalene. We are always worried when the drug seeps into the anterior scalene because the phrenic nerve is always on your way. Why I'm saying is supraclavicular is, you can see the anterior scalene, the middle scalene, the first nerve that exits the brachial plexus is here, suprascapular nerve. Okay, guys, the chapter is over. Now I'm going to leave some queries to you. Decades we are doing paresthesia. Paresthesia means no block. You won't get the block. That's what the teachers taught us. But when we perform a paresthesia guided block, how are we escaping from nerve injuries? In ultrasound guided, when you insert the needle, go close to the nerve, the patient may say either lift her limb or say, I'm feeling shock. So that means paresthesia. So if the patient says so, your needle is very well close to your breaching your paraneurium or breaching the neural elements of the brachial plexus. And you keep the needle in the same place there, and then you give the drug. You blow the whole area. You may be injuring few of the vesicles. And you may be doing 1,000 blocks or 2000 blocks, but none of the patients or only one patient in your life or two patients in your life may present with some prolonged duration of block, and you give them steroids, or you have a prolonged block for 4 days, and patient is unable to lift the limb for 4 days after your block, and patient comes out with good recovery in months. But how does it happen? This is my own perspective. I want to tell you that this is one vesicle, this is one vesicle, and each vesicle is always connected, called as vesicular interconnections. Ladies and gentlemen, the nerve doesn't look like this. They're all a network. This is a huge network. When you take a histological cut section, when you happen to injure this vesicle and you are traumatizing this vesicle, or you have taken even a punch biopsy of this vesicle, the inflammation of this vesicle is always carried on. What the plastic surgeons do for ulnar nerve transfer, it's usually they see whether they are bivesicular or trivesicular. They cut the one vesicle and they do the transfer. Even in brachial plexus, they take the C7 and they do the transfer, because the inflammation of that vesicle is always taken off. This is my perspective. I'm not challenging you people. In years to come, there will be scientists who will be proving that for eras of decades, how we are escaping out of nerve injury. This is maybe a reason for it. And I've used where we are heading towards the future is lots of probes to come. There are ultra high frequency probes. This is the information that I'm giving you. I've used around 250.
With these machines, I have used around 25 megahertz, 50 megahertz, and 75 megahertz to see my own brachial plexus.
That is all in my brain. I can't deliver it to you because of ethical issues. I know how monovesicular, what you see there, what you see here, with ultrasound. When you see here with ultrasound, they are not monovesicular; they are multivesicular. That is how these probes will deliver information to you. That is why this monovesicular is being seen like this, but this is not so. This is a median nerve. This is taken from the net, but I've seen it myself. But in eras to come, what the future is going to be, ladies and gentlemen, get involved with ultrasound, improve your knowledge, get into the low volume local anesthetic. Those are there are patients demanding for low volume blocks. The future is always targeted nerve injuries. Thank you.